Okay, let's start. So, distinguished guests, esteemed participants, ladies and gentlemen, I'm Vincent Chung, Associate Professor of the Jockey Club School of Public Health and Primary Care at the Chinese University of Hong Kong. As the moderator, I welcome you to the third webinar of the 5 Implementation Science Seminar to be held in these 2 weeks. So, implementation science, often referred as the science of getting research into practice, focuses on bridging the gap between evidence-based intervention and their successful integration into real-world setting. It is a multidisciplinary field that draws upon various disciplines, including public health, psychology, sociology, management, and many others. So at the third seminar of the series, we will focus on the concepts and theories of potential utility in implementation science, drawing on other disciplines. So throughout the next 2.5 hours, we will have the privilege of hearing from 2 renowned experts in the field who will share their valuable insights and expertise. So today we take a more theoretical perspective on implementation science. The first lecture will be delivered by Professor Sarah Birken on organizational theory to understand the challenges of implementation. And the second lecture will be taught by Professor Per Nilsen on utilizing theoretical approaches from other disciplines and fields. We hope this seminar will provide a platform for knowledge exchange among participants and our experts. I encourage you to actively engage in the section, ask questions, and or share your own experiences or perspective. Please type your questions or your thoughts at the chat box. I will share it to the speaker for response. And since we only have limited Q&A time, we will not be able to select all the questions to response. So without further ado, let me introduce the first speaker, Professor Sarah Birken. She is an associate professor in the Department of Implementation Science in the School of Medicine at Wake Forest University School of Medicine and a member of the Comprehensive Cancer Care Center, USA. Dr. Birken's research focuses on translating evidence into practice. Specifically, she studies middle managers' role in implementing evidence-based practice, the implementation of innovations in cancer care and improving care coordination, as well as the selection and application of implementation theories. So now I will pass the time to Sarah. Thank you. Thank you, Sarah.
Great. Thank you so much for that kind introduction. And thanks for especially to Per for his flexibility in switching up the order of these presentations. I think it'll be nice for you all to hear about theoretical perspectives from multiple disciplines, but I get to give you a taste of using theory from another discipline in this talk. My research focuses on relationships among organizations that can influence implementation of evidence-based practices. So this is what I think about all day, every day. And so I'm excited to talk with you all about it today. So I'm going to start out with an example, an empirical example from my own research that I've been studying for many years now, and that is the continued use of oncology visits among cancer survivors. So what we find is that once somebody has gone through cancer, they tend to stay with their oncologist. And sometimes this is good because they have increased risk of recurrence or a new cancer, or they have late effects, or they continue to be chemotherapy that requires management by an oncology team. The problem, though, is that most cancer survivors who remain in oncology actually don't require oncology services. These patients have all sorts of comorbid conditions, oftentimes, and other issues that are best addressed by other providers, namely primary care providers who can address health maintenance services such as vaccination, pap smears, these sorts of services that oncologists are not trained to provide. And another problem with survivors continuing to get care from oncologists is that, at least in the US, there aren't enough oncologists to withstand the large and growing number of survivors who demand their services. And what this means is that new cancer patients often have appointments that are delayed. So when we think about an implementation problem such as this, the problem of ensuring that survivors get evidence-based care, which is going back to a primary care provider, I like to think about it in terms of a popular implementation framework. This is the consolidated framework for implementation research. And the benefit of using a determinant framework such as this from implementation science is that you can start to think about where the issues are and start to map those issues onto strategies to address the problem. So at the middle here, you see the individuals involved, and we have tools like the behavior change wheel that allows you to map individual psychological constructs such as motivation onto strategies such as incentives. But when we have issues, for example, in the inner or outer setting, we don't have a tool like the behavior change wheel to identify relevant strategies. And I'll give you a taste of what we've identified as potential mechanisms, but we'll get far more into this later on. So let's go back to this empirical example that I provided earlier. Why do we see this problem of survivors continuing to stay in oncology? You can think about it in terms of levels of the socio-ecological framework. So starting down here at the bottom, there are individual patient factors and individual provider factors, but something that I see over and over again in the literature and my own research is this strong relationship that develops between patients and providers during the course of cancer treatment. But there are other things beyond individual patients and individual providers and their relationship that influence this, that go far beyond what we typically think of in terms of factors that influence implementation. One is the professionalization of oncologists that suggests that their clinical judgment is the most important thing, and that they should do what they were taught to do and not worry about other people's perspectives. There might be the governance structure of the organization. There seems to be a disconnect, at least in my organization, between what operational experts think would be best and what clinicians would like. So, for example, I found in my research that operational leaders hide the problems of capacity from clinicians. So clinicians don't know that there is any issue with new patients getting delayed treatment. There's also this issue of competition among hospitals. So the hospitals are under pressure to get patients to come to their facility, and ensuring that patients continue to come back, at least in the US, is good in terms of generating revenue and avoiding patients going to other cancer programs where they might be seen. I won't go through the other examples, but what I'm trying to convey here is that there are a lot of things that happen at the organization level and beyond, relationships between organizations that influence implementation problems. So as much as I'm interested in what influences implementation, I'm more interested in why and how these factors influence implementation. And the reason I'm so interested in why and how these things influence implementation is because to change things, to improve implementation of evidence-based practice, we need strategies. And strategies operate on the mechanisms underlying the relationship between these factors and implementation. So I was trained in organization theory, And so I've always kind of thought about the organizational influences on implementation. And so when I began training in the field of implementation science, I was very surprised to see a very strong influence of health psychologists in the field, and perspectives that really related to factors at the individual provider level and factors at the individual patient level, and less on these things that I have seen to be very influential in implementation. Um, and the problem with continuing to think about the individual level only is that we know that we don't have any answers yet about implementation strategies. We don't see that the implementation strategies we so often think about, like external facilitation or incentives or audit and feedback, really only have very modest effect sizes. So there is a lot of potential for organization theories to improve the state of the science in terms of how we can incorporate a consideration of the context where implementation happens, to promote the integration of evidence-based practices. So I want to talk through a few key definitions to make sure we're all on the same page. Theories explain how or why constructs, these ideas that are often operationalized as variables, relate to one another. So, for example, institutional theory explains why professionalization may deter the implementation of evidence-based practices. And this stands in contrast to frameworks like the Consolidated Framework for Implementation Research, which just identifies the factors that influence implementation rather than how or why those relate to one another. And the constructs are these factors that are included in theories. Organizations are social units. So an organization could be two people working toward a common objective. And we think in terms of the organization itself or its relationships with other organizations. So you can think of a field of hospitals in a city that might compete for patients. Or you can think about a hospital and a skilled nursing facility and the government. They all comprise a field of organizations. So organization theories explain all sorts of things that I think are incredibly relevant to implementation, like why do organizations come to exist at all? Why do new healthcare organizations get established, for example? And why do some healthcare organizations die? This happens in the US all the time with small rural hospitals closing. They explain why some organizations do better than others. It explains operational decisions. They explain why organizations tend to look like each other and start to do the same things as each other, and so many other things. So what I find most compelling about organization theories is that they start to help us think about the relationships among organizations and why those interactions happen the way they do. So, for example, why organizations might engage in coalitions. They also predict implementation outcomes based on these contextual features. And they have the potential to start helping us think about why a certain policy might affect the implementation of an evidence-based practice. The problem is that these theories have been around for 60 years in some cases. And to me and many of my colleagues, they seem like very relevant ways of thinking about implementation, but they remain very underutilized in implementation science. But they can be inaccessible and difficult to understand for people without the training. And it just takes a lot of time to become familiar with these theories. So with that in mind, my colleagues and I, including Per and others, have engaged in a series of studies with the objective of bringing organization theories into implementation science. And this has involved developing summaries of organization theories, as well as developing a framework to help organize thinking around constructs that may be useful to think about in implementation studies. So on the left side of the screen, I've listed a few different studies that we've written up, but most helpful here you may find on the right side, and it's probably very difficult to see, but it's simply our process by which we went through this process of identifying relevant organization theories and then creating forms to summarize in a standardized form the organization theories that we identified. So I'll go through these one by one. Let's see, I'm going to minimize this. Okay. So we began this process by surveying scholars who were familiar with both organization science and implementation science. And they organized a subset of organization theories that they believed to be relevant to implementation science. So then a group of us who participate in the Cancer Prevention and Control Research Network, or CPCRN, we paired up and we took from the original texts of these organization theories written up in journals such as, let's see, what journals might these appear in? Administrative Science Quarterly, and other organization science journals, strategic management journals. We took out the specific constructs and propositions, which I'll describe in just a moment, and identified potential points of relevance to implementation science. We did that independently and then reconciled any discrepancies. And then a third investigator reviewed the forms to make sure that they were accurate and complete based on their understanding of the theory. So I said that I'd talk about propositions, and propositions are important because these are the things that help us to identify implementation strategies that may be useful for addressing factors at the organization level that are influencing implementation. So propositions suggest a relationship between two or more constructs, and more specifically, they identify the mechanisms. They explain how and why those constructs relate to each other, and therefore they point to strategies. So using the example I've talked about before of professionalization of physicians, for example, why that might deter them from implementing an evidence-based practice. Well, institutional theory suggests that that's because the professionalization process suggests that healthcare providers should adhere to common norms in the field, which makes their practice resistant to change. So here are a couple of examples, additional examples, and I'm happy to share these slides. I realize it's a lot of words. But contingency theory, for example, talks about how the most effective way to structure and coordinate tasks in an organization depends on what that organization looks like and what things look like in its organizational field, what it looks like in the environment. From this process of identifying organization theories, and you see the ones that we identified here, there are 9 of them. They include 70 constructs and 65 propositions. So that's a lot. So we wanted to make these accessible to implementation scientists who may not know these organization theories. And so we ended up with 9 abstraction forms, and you can see them all. You're not expected to be able to read these. These are just to demonstrate that these are the forms that you could find by going onto the website cpcrn.org. And in the resources, you can find these abstraction forms. And what are included in the abstraction forms are an overview of, this is an example from institutional theory. So on the forms, you can see that there's an overview of the theory that kind of gives you a general idea of what the theory says. There's also a list of articles where this theory has been applied to implementation science, so you can see how it's been done before. We also list the constructs within the theory that we identified from the original articles. And then the propositions that the theory includes or suggests. And then ideas about why the theory and how the theory might be relevant to implementation science. We also include, to the extent possible, articles that criticize the theory or critique it, or place bounds on the theory, suggest when it is and is not relevant. And then finally, we include the original references that we used to develop the forms. So here are the organization theories and all of the constructs. Again, I don't expect you to read through these, but I wanted to put them here so you get a sense of what they are. And I am going to give you, since I believe I have time, I'm going to talk through what just a snippet of what each of these theories says. So let's see. So I will start with on the upper left-hand corner, complexity theory. So what complexity theory says, let's see. Let's see if I can get my note on this. Okay, so complexity theory says that change happens in complex adaptive systems. So when we're thinking about implementation, we need to think about implementation not with just a provider and a patient, for example, not even just in a clinical unit, and not even just within the organization. We need to think about implementation happening in a complex system of organizations that depend on one another to do the work that they do. Contingency theory suggests, again, I mentioned before, that the effectiveness of an organization and how it works depends on different features of the organization itself, the work that is being conducted, and its relationships with other organizations. Institutional theory says that organizations tend to do things the same way for a few different reasons. One is that they are compelled to do so by laws, by accreditation policies, but they are also compelled to do things in similar ways because when operational leaders don't know the best course of action, they look to other organizations that they think are doing things well or have good reputations and do things that way. We also talked about professionalization. Those are kind of the professional norms that influence the way organizations do things. Transaction cost economics suggests that organizations are striving for efficiency. They want to spend the least amount of money and use the fewest resources to get the work done. Let's see, the network perspective talks about relationships within and among organizations. And it says that the structure and the character of those relationships influences the work that gets done. And I'll share just a little anecdote. I have a colleague who's a breast surgeon named Clara Lee, and she found that a surgeon's proximity to the organizational liaison to the accrediting body were the most likely to implement evidence-based practices related to surgery. Organizational learning says that organizations create, retain, and transfer knowledge at different rates based on their abilities. and this influences their performance. Resource dependency theory talks about the balance that organizations attempt to strike between how reliant they are on other organizations for resources and their independence. So they want to spend the least amount of resources, but they also want to depend on other organizations as little as possible to get their work done. Population ecology talks about how organizations compete with each other for scarce resources within a field. So you can think about resources like in the US right now, we have a nursing shortage. So healthcare organizations are competing with each other to hire nurses, which means it's incredibly expensive to hire nurses right now. Sociotechnical theory talks about how there are subsystems within organizations that interact with each other to get the work done. And that the kind of technical subsystems, like the technology and the resources that are used, interact with the social subsystems. So how people interact with each other. And then the governance of the organization all have to be in alignment to optimize performance. Okay, so that's a lot, right? There are a lot of different organization theories. So it's no wonder that they're not used very often in implementation science. They're pretty specific. So for that reason, we undertook this effort to develop a domains framework. So you may have heard in previous sessions reference to the theoretical domains framework that Susan Mickey developed based on 33 psychological theories. And those psychological theories think about things like motivation and capabilities and knowledge and skills and very individually focused factors. And so we sought to develop a framework very similar to what Susan Mickey did, but comprised of organization theories rather than psychological theories. So we went about this process using a combination of concept mapping and a consensus building process. So I'm going to skim over this process because I think it's far less interesting than the results. So I'll say very briefly that this process involved so if you see here on the left, you can see that these are constructs from the organization theories. And what we asked people who participated in this exercise to do is to click and drag these constructs into piles. These are piles. And then they could go in and name the piles of constructs that they thought go together conceptually. And ideally, what happens in a concept mapping process is that those groupings show up as shapes. And we can name those shapes, and they represent domains, groupings of constructs that are conceptually similar. I've done this with other projects. For those of you who were on Monday, this is how TCAST was created. And it went very, very well and was very straightforward. And that is not what happened in this project. In this project, there was very little coherence in the results. And so we had to go through this consensus building process where we met several times with work group members participating in the strategic direction of this process to identify workable solutions for potential domains of this organization theory for implementation science framework. And we did this over a series of meetings and went through this process until we had resolved all discrepancies and identified a set of domains that we all agreed were the most relevant. So we ended up with originally a 10 cluster solution. And by cluster in this sense, I mean domains of constructs. What we resulted with was 6 domains, and they're listed here. So I'm going to spend most of the rest of our time together talking through what these 6 domains are about. And something you may notice is that there's a lot of overlap between the individual theories and the domains, but not entirely. Okay, so this is our first domain. It's organizational characteristics. So you might be more familiar with thinking about individuals, and oftentimes in health services research, we like to describe the individual, right? We say how old they are, we say their sex or gender, maybe their race, ethnicity, nationality. This domain is very much like that. We're describing the organization. How old is it? What's its history in terms of successes, acquisitions, new service lines? What kind of failures have they experienced? Maybe the closure of some services. What professionals are they comprised of? So I'm currently in Asheville, North Carolina, where I'm attending a conference comprised of oncologists and who work in community oncology programs. And they actually look quite different from one another because there are some community oncology programs where they can't hire surgeons. So they may have radiation oncologists and medical oncologists, but they don't have surgical oncologists, for example. Size is another issue. Very large healthcare organizations look very different from very small organizations. My internet connection is okay.
Yeah,
Is everything okay? Yeah.
Everything is okay.
Okay, good. Okay. All right. So the second domain is about how the organization is governed, and the way I think of this. I remember in high school learning about biology and about the cell and about the nucleus of the cell, directing what the cell would do. And this domain is very much about the nucleus of the organization, how the organization is tied together or not. I know a lot of organizations are not tied together very well, but it's important to think about not only the explicit governance and operations systems within an organization, like the objective policies and procedures within an organization. It's also very important to think about the implicit or informal governance and operations of an organization. These are the kind of unwritten rules of an organization that influence how things are done. We all, I can imagine, are familiar with situations in an organization where the rules may be written a certain way, but everybody knows that it's done in another way. This is what that domain gets at. This third domain is about the work that is done in an organization and what processes are required to do that work. And this is important because healthcare organizations are very different in the work that they do and the kind of processes that are used. So my father is a plastic surgeon, and he has a freestanding operation room, and he has privileges at a local hospital where he can admit patients if necessary. But you can imagine that his little practice, this freestanding operating room, is very different in the way it does work and the processes it uses and the tasks required then one of the rural community oncology programs that I am talking to representatives here at this conference about. I find it very interesting that in implementation science, we tend to think about implementation strategies as without considering how very different healthcare organizations can be in the work that they tend to do and how they accomplish that work. Okay, so this is the last domain that relates to the organization specifically. And this relates to how organizations take in information, how they process that information, and how they then disseminate that knowledge or not within the organization. And this happens very differently in different organizations. And has really strong implications for the implementation of evidence-based practices. So a specific interest of mine is accreditation. So for cancer hospitals, for example, in the US, the Commission on Cancer is an accreditation body, and cancer hospitals all across the US, 1,500 of them, seek accreditation from the Commission on Cancer, and the Commission on Cancer convenes a panel of experts to identify standards that member institutions then have to adhere to in order to be accredited by the Commission on Cancer. And this is totally fascinating to me because the way that the individual accredited organizations make sense of the standards is highly variable. And in my estimation, the reason that they're so variable is because they have different ways of processing information about what those standards mean. So this domain relates to all of the features of how that learning happens. Okay, so the last two domains relate not to the organization itself, but relate to the relationship between the focal organization and the population of organizations with which it exists. And you can again think about this as similar organizations to the focal organization. So, competitor hospitals in a field. But you can also think about the hospital and the government, the local government, the federal government. You can think about the other healthcare organizations to which the focal organization refers. So something that I think about a lot is, when surgery happens, oftentimes, at least in the US, patients are referred to skilled nursing facilities where they receive long-term care following the surgery. So thinking about that population of organizations. So you can think about how many features of that population are relevant, like how many resources are available. So we know, for example, in the US, that in urban locations, in large cities, it's a little bit easier to hire people, to hire providers and staff. In rural areas, it's more difficult. At munificent organization. And then the final domain relates to the character of the relationships among organizations. So I'm just going to give you an example of a recent study that I did that related to surgical readmissions. So I studied readmissions following discharge from lower limb extremity amputation. And what I found was that the skilled nursing facilities that patients were sent out to, there are a lot of them, but the ones that the healthcare organization that I work in has the strongest relationships, they send the most patients there, things go better because the network is quite tight. The ability to communicate across providers, they know each other very well. The surgeons understand the way things work in that particular organization. They have a financial relationship with them that make things go better than the relationships with smaller, less frequently referred to skilled nursing facilities. And so these institutional linkages and the amount of interdependence among these organizations have strong implications for the way things go in these organizations. Okay, so I'd just like to conclude by kind of giving you a high level of what we've done. I talked very specifically, but now I'd like to kind of give you a sense of what I think we did, what I think we contributed, and where I think we need to go. So we took 70 constructs from 9 organization theories, and we distilled them into 6 domains. And our goal was to help implementation scientists to think about all of the things that are happening within and beyond organizations that influence implementation, so that instead of just thinking about organizational factors as kind of a monolith, we think in more nuanced ways about what might be influencing implementation. And these theories explain mechanisms that point to strategies that can be used to improve implementation. And we can start to test these hypothesized relationships to figure out what the relationship is, if there is in fact a relationship, and under what circumstances we can start to model these relationships in empirical studies. So I want to circle back to that example that I used from my own empirical research to start to think about what the implications might be of these insights from organization theory for cancer survivors continuing to stay with oncologists. So one is to think about reframing, for example, the concern that I have heard that patients will stop coming to our organization if they think they can't continue to come see an oncologist. But if we think about our primary care services as part of the broader organization, and we ensure that these patients have a primary care provider to go to, whom the patient trusts and whom the oncologist trusts, then we don't worry about competition because they'll remain in the organization, but just a different part of it. We can think about, the challenge associated with coordinating with other healthcare professionals like primary care providers by addressing this with mechanisms like nurse navigators who can do the work of coordinating information and services between oncologists and primary care providers. So I'll just close by thanking you for your time, and I'm really happy to take any questions, but I want to acknowledge the large number of people who collaborated on this work. It really was a team effort and has spanned for many, many years. So I'm grateful for the engagement of scholars across the world in getting this work done. So thank you for your time.
Thank you very much, Sarah, for your excellent lecture and introduce this new perspective on using organizational theories in implementation science. So let us see if there are any questions from the audience for Sarah. So
I could ask you one question. I'm a small part of this huge undertaking. Do you think, why the focus on psychological theories, do you think it's because they have the tools, the surveys, or could it also be that many psychologists were the sort of first to enter this field?
I think those are both really reasonable hypotheses about this. I think that the point about the tools to assess is a very good one, because we know actually from work that Brian Weiner and his colleagues have done that it's very difficult to measure some of these organization level constructs, because of course organizations themselves can't answer survey questions. We have to ask individuals within the organization. But I think that it is possible. So Brian Weiner has identified best practices for surveying individuals within organizations about organization level constructs. So one of the things he found, for example, is that the most valid way to ask questions about organizational constructs is by asking about things with the organization in mind. So for example, you can't just ask individuals for their individual perspective and then aggregate and take the average of all of them. It's better to ask everybody about what happens within the organization and look at it from that perspective. So I think that's an opportunity in the field. I also think another opportunity is to use administrative data to start to collect this. So in the US, we have something called the American Hospital Association survey. They do an annual survey where representatives from the hospital, operational leaders, report on characteristics of the hospital and its operations and its composition. So that's potentially useful, but not as widely used in research as we might hope. And training, right? I think there hasn't been kind of the historical link between organization science and implementation science the way it has been done in psychology.
And I think that is surprising, I think, because I think this is really research on organizational changes. And I wonder if you surveyed people in hospitals or primary care and asked them what would they say is the most important influences on their use of new practices, I think many would say come up with resources, my manager or whatever, sort of more organizational explanations. I'm pretty sure, but still we are a bit fixated on measuring at the individual level. I think it's because also, I mean, we have so many different factors, so many barriers facilitators, and even if there are, say, 20 at an individual level, it might still be the 2 or 3 at an organizational level that are the most significant. So it's not sort of the count, the number, it's their significance. In the comments?
Yeah, I totally agree. And in fact, so I'll just share a little anecdote. I was with a colleague yesterday. We're in Asheville and we went to go take a yoga class, which was really fun. And she's trained in yoga, and she was pointing out different characteristics of different people, you know, people who tend to be more anxious to people who tend to be less flexible. And I said, oh, I'm definitely anxious and less flexible. And she said, well, part of that you don't have any control over because our culture in the United States is very anxiety producing. And I think this is exactly what you're saying. You know, our ability to act as individuals is highly constrained by what is happening at collective levels. And so in my estimation, the majority of our efforts should be focused on collective levels because they will have impacts on individuals' ability to perform.
Yeah, I totally agree, and exactly that is what I'm going to talk a bit about, because I think one example is if you see people at a red light, and if everybody is sort of crossing the street regardless of the red light, you sort of follow the herd. But if you're standing there alone, you might be a bit more hesitant. So I think, I mean, I would say that Sweden is also a very individualistic culture, but still, I think we underestimate the importance of the culture in which we are. But it's like, well, what is it they say? Fish don't see water. We don't sort of recognize that, because we would like to think of ourselves as very independent minded and rational, etc. And I think real world practice does not really support that.
Yeah, and I wish I could remember the reference so that I could share it, but there is some evidence that when things are going well, when you ask people why they're going well, they attribute it to themselves.
Yeah.
Oh, I'm very good, I'm very skilled, I'm very motivated. But when things go poorly, they tend to blame things other than themselves. I don't have the time, I don't have the resources, my manager. So we know implementation usually doesn't go well. So we should be looking at organization levels, I think, for this reason.
So Sarah, so if we are going to use more organizational theories in the future in implementation science, do you think we will have more organizational level implementation strategies in the future, which inform like the management level people to actually create a better environment that facilitate implementation? Because
that is, yeah.
Because let's say, let me use the behavioral change field, for example. Probably many of the interventions are quite individual focused. So we see much less, organizational level implementation strategy. Do you think your work will actually lead to a more diverse portfolio of implementation strategy that target organizations and management?
I hope so. It's very interesting because I recently, just out of curiosity, looked at the ERIC list, expert recommended implementation. Oh, anyway, a list of 76 strategies. And I looked through to kind of ask this question about kind of the level at which commonly used implementation strategies operate. And I haven't looked thoroughly, but my sense is that a lot of the strategies that are listed on that list are actually organizational, or could be construed as organizational, although I'm not familiar enough with them to know for sure. But still, the implementation strategies that I see in the literature that are being tested tend to be very individual. Organization, like educational strategies, training, facilitation, as opposed to contracting or financing. Those are in the list of strategies, but to my knowledge, there hasn't been an effort to there hasn't been an effort to identify the levels at which these strategies operate. So I'd be very interested, Per, I don't know if you're interested in collaborating on that effort. I've reached out to a couple of people because I think we need to know the levels at which these operate so that we can help healthcare professionals have access to these kind of organization level strategies.
Yeah, I think that's a highly worthwhile effort, and I do think that Byron Powell's list is probably quite incomplete. There could be many more organizational strategies. We had a question on the 70 constructs, 70,
Yes.
and these, you showed them, and I think we had them yesterday, or if it was Monday also. They have been grouped into 9 domains or types.
Yeah, so the reason that there are only 65 propositions is because there isn't a one-to-one match between constructs and propositions. So, right, a proposition has to relate at least 2 constructs. And oftentimes it's relating, each construct to an outcome of interest. But in some cases, the construct is not expected to have a direct influence on the outcome. Sometimes it's a moderated or mediated influence. Let's see if I can come up with an example off the top of my head. I don't know if I'll be able to come up with an example off the top of my head, but maybe something like the availability of resources within an environment, the influence of that on implementation will be moderated by the ability of the organization to integrate knowledge, right? So you may have very few resources available to you, but if you have very strong systems of kind of processing information and resources, then the relative lack of resources won't matter as much. So in that case, the kind of knowledge subsystems is a mediator, so wouldn't show up independently in a proposition.
I think
Yeah.
I misinterpreted the question. I thought the question was about Powell's list of 60 plus strategies, and they have been grouped into, I think it's 9 types.
Oh, have they? Okay.
But this was about the 6 domains of the organizational,
right.
you presented today.
Yeah, but you're right that I do think it's an important point that the ERIC strategies list, it was derived from the literature, and we know that a lot of strategies happen that have never been published. So I think there's a lot of potential to improve upon that list.
Definitely.
Well, I really appreciate the opportunity to present this work. It was fun, and Per, always fun thinking about these issues with you specifically. And now I'll go downstairs and I'll give my next talk.
For squeezing time for us. Thank you very much. Thank you.
Yes, thank you so much.
Thank you. Bye.
Bye-bye.
Bye-bye.
Okay, now up next, we have a presentation from Professor Per Nilsen. He is Professor of Social Medicine and Public Health in Linköping University and a Professor of Implementation Science at Halmstad University, Sweden. He is also a visiting professor at CHK. Professor Nilsen is an economist by training at Stockholm School of Economics. He was responsible for building research and educational program on implementation science at Linköping University, including a PhD course, which is running annually since 2011. He takes particular interest in applying concepts and theories from beyond implementation science for improved understanding of the challenges involved in achieving practice change. Interestingly, Professor Nilsen and Professor Birken has been collaborating since 2017 when Professor Nilsen visited us at CHK for the first time, and they started communicating about doing something together as they recognize that they have many shared interests in implementation science. So without further ado, let me pass the time to Professor Nilsen.
Yes, thank you. So the theme of theories continue, and in my presentation, organizational theories is a smaller part, but they are part of the theories and concepts at 3 levels. And I'm exclusively looking at theories and concepts from other fields. There are some developed in the field. We talked about normalization process theory and COM-B, etc. But this is looking beyond. The aim is to provide a brief overview to look at potentially relevant theories and concepts at these 3 levels. And maybe, yeah, I think Sarah also explained it. You could talk about the how and why something happens, but you could also describe a theory as a set of concepts, or you could use constructs, principle definitions that make sense of something by specifying relations. And here is the example of theory of planned behavior. And then we would say that the concepts here are attitude, self-efficacy, etc. And this theory specifies the relations between them for the understanding of what influences behaviors. Concepts are, you could call them the building block of theories. So attitudes is a building block of the theory of planned behavior, for example. And it's usually concepts or constructs that we try to measure. So the contents here, and I'm just showing some socio-ecological models that you can divide this in many different ways. But I went for 3 levels. So in the individual level theories, which will be the most familiar to implementation researchers, are these 3. And what I consider underused, although recognized as important, leadership culture, and also the almost forgotten, I think, routinization theory. And then a couple of organization level theories, an organizational climate, how people, their health in the organization is obvious influence. And complexity theory is really complex, but it sort of tries to explain how and why it is this complexity in organizations. And then some wrapping up with some final questions. So starting with this individual level, the dominant ones. And the sort of assumption here is that, I would say this, the premise is that it is, after all, often the individual healthcare worker. If we are talking about healthcare, it could be the teacher or a social worker who ultimately decides to use or not to use an evidence-based practice. Not always, it could be mandated, so it's not really a free choice. But oftentimes, it is the individual who decides. And psychology is traditionally the study of the individual. So it seems highly applicable. And I will briefly talk about three perspectives or three areas of theories on behavior change, individuals' behavior change. And behaviorism dates back more than 100 years. It was a term coined 1913. And the focus here is on behaviors. And operant learning is, I would say, still alive and well. Because what are financial incentives but behaviorism? That certain performances or actions are rewarded, whereas others might be punished. So it's sort of quite simple. I guess it is like you train a dog or something, that you reward the desirable behavior, and there might be some punishment for the non-desirable. And I would say that financial incentives is based on the behaviorist principle. So this is underlying or a theory behind the strategy financial incentive, which is used quite a lot, at least in Sweden. For example, to improve patient safety, there was hospitals were rewarded if they could get down the antibiotic prescriptions, because they have been quite high. So it's a strategy that is used to implement, and you could also say de-implement low value care. And then we have a sort of response to behaviorism in the form of social cognitive theories. And we talk about this cognitive revolution, where we sort of compared human beings to computers almost. And here, the view of a human being is that we are always very rational. We make deliberate, conscious decisions. And we sort of weigh the utility, the attitudes, before deciding on different actions. Sort of a highly rational view of human beings. And I usually say that this might be the case, this cognitive process might be quite relevant if we are going to buy an apartment or a car or something, where we probably would weigh the pros and cons in a more sort of conscious, effortful process. And you recognize these because these are the basis for theoretical domains framework and COM-B, and they all look quite similar. But here, as you can see, for example, social cognitive theory, before deciding on engaging in a behavior, we need to be equipped with self-efficacy, a belief that we are able to perform this behavior. And we set goals to pursue this behavior, for example, taking part in a course. And outcome expectations that we sort of consider, if we engage in this behavior, how will I respond physically, socially, and self-evaluative? So it's a very deliberate process, and here even more, but they are quite similar, and they have been collected or assembled into theoretical domains frameworks. less so in consolidated framework for implementation research, the SPHERE. It touches on these, but there is quite a difference, because here it's much more closer to the psychological theories. But then these social cognitive theories have been critiqued for they ignore our non-reflective processes, and they assume that we are always sort of acting consciously. But dual process theories, I would say, provide a broader explanation of our cognitive processes and behaviors, because we do have a range of cognitive biases and implicit biases that clearly suggest that we are boundedly rational, not always so rational. And then Daniel Kahneman received the Nobel Prize in Economy quite a few years ago, for his research into the two different systems, where the system 2 is very much like I described before, social cognitive theories, and his research is showing that the system 1, based on intuition and instinct, might play a key part in many of our decisions. And cognitive biases, I just put up 2. Selection biases is that the results might not be really generalizable, because there's been a selection bias, and this figure here indicates that a novelty bias is when we sort of take for granted that, for example, a newer equipment or a newer intervention is inherently better performing than something older. It's sort of uncritical acceptance that novelty should or is better. And implicit biases, also out of awareness, but this is tied to attitudes. And you could say that here is the whole thing about stereotyping and even prejudice, that we likely often out of our own awareness have some prejudice. We, for example, like to talk about different ages in baby boomers, millennials, etc., sort of assuming that they have certain characteristics. And this has been shown in research to influence the treatment or interventions people receive in healthcare. For example, in alcohol prevention, it can be the treatment or how you are received can be very much influenced by your age, social background, I would say, often important. So these are sort of biases which make us not always so rational. And there are numerous dual process theories, and there are numerous books. So this sort of indicates that this is recognized as an important feature of human beings. And I'm thinking that if we always focus on education and training, sort of going the rational mode, assuming that that is what is lacking, then we might make the mistake of overlooking that the behavior that is going to be changed is probably could be determined much more by type 1 processes. So that's why I think it's important. Also, other similar principles, novice to expert theory from in nursing says that we sort of start as a novice and more dependent on knowledge in books and guidelines, but as we progress and become experts, we tend to become more intuitive. So it's quite similar to system 1. And habit theory is also very similar, I think. And a habit would be something that is generated, developed, and is similar to system 1. I won't go into any details. And habits have also become, I would say, in the last 20 years or so. So there seems to be a wider recognition that this idea about trying to change behavior through system 2 is sort of taking a beating, that we recognize that many of the behaviors that are going to be changed if you implement a new practice might be strongly habitual, based on intuition and more unconscious processes. And Sebastian Potthoff, a German researcher, in his thesis, I should actually have put his reference here. He came to the conclusion that habits might be at play in healthcare for these sort of frequently and less complex behaviors. So they might be, could be quite difficult to change with a new, by implementing a new guideline or a new way of working. And hopefully more complex behaviors are not overly habitual. His conclusion was that they are more relying on conscious cognitive processes. And interestingly enough, COM-B again, and it does actually address automatic, would be similar to habits, although I think it's sort of a smaller part. So I would consider this a social cognitive theory, but it does account for the possibility that motivation is not reflected, not deliberate. So that's at least an attempt to factor in the system 1, the habits, but it's not very emphasized. And then, if you have any questions, I can right now not see the, but maybe you can check for that, Vincent, if there are any questions or anything should be.
Yeah, there's but that question, there's no question for you yet. Yeah.
Okay.
Yeah.
So everything is crystal clear, hopefully. Well, social group level theories and concepts, I think these are important. And human beings, we are social creatures, however independent we would like to view us. We need support and recognition provided by peers, and social relationships are essential to our well-being. I think I read somewhere that we are probably the most herd animal of all animals, that we are that we survived because we grouped together. But this is not really evident at all in psychological theories, to some extent, because they do account for social norms, etc. And yeah, I would say that some social group level theories are found in some of the TMFs. But another question is if we really capture them. So I will talk a bit about culture, leadership, and routinization. So culture, I guess it's organizational culture that is sort of most popularized. But you could talk about, yeah, I'll get to that. But key principle is culture is something you learn, and being the shared values, norms, assumptions, and perceptions that develop in a social group. And I usually think that you can compare it to learning a language. It's very difficult to learn a language if you are, it takes time. And I know the Cantonese language with all the different intonations must be very difficult if you come from abroad and as a grown-up try to learn that. So culture is something that you learn over time. Also importantly, it's not only organizational culture, and I do think it's difficult to talk about organizational culture in healthcare, because I think the most important level is the profession level, that the shared values, norms, etc. among physicians can be very strong, and among nurses very strong but different, and etc. etc. I also work with physiotherapists, and they're also quite identifiable as a social group. So I think I would say that the profession can be a very important level when we do research on implementation. If the profession, physicians, as a group, do not approve of something new that is going, a new guideline, for example, it does not really matter if we do a survey and individual physicians say that this new guideline is good, is beneficial, etc., because it's how they act as a group that might be the most important. And I usually show this. I think there's some truth in this. And I usually say that in Sweden, we are experts at everything above surface. We have often put this into writing, goals, procedures, policies, and that's fine. And you probably do it here as well. But the key thing is what is under the surface, because these aspects of the culture really determines how people behave, their behaviors. So if you say that you have a strategy of being positive to new interventions and working evidence-based practice, but if the sort of tradition is that you are skeptical of new innovations, etc., it's not going to be aligned. So culture is important. And culture is sort of the other side of the coin of leadership, because leaders, more than the sort of average employee, has a chance of influencing the culture, even though culture is not something you change very quickly. So leadership is a process of social influence. And you could call all of these social influencers on the internet, of which there are quite many in Sweden and elsewhere, that they are sort of leaders. I think they influence at least the younger generations quite a lot, so they could be considered leaders. And leadership theories, usually it started when the research on leaders began, that it was sort of some are born leaders and others are born followers. That is sort of not how it's viewed currently or in a modern context. Rather, it's more about the interaction between the leader and environment. So it's developed. But importantly, that leaders are culture creators. So really, it's sort of this two-way direction, that a certain culture could foster or support a certain leader, and this leader could influence culture. But a colleague, Per Nilsen, and I think that's true, that we might be overconfident that there is sort of a causal relationship between leader and outcomes. I think that's difficult to prove. But leadership and culture sort of go hand in hand. And culture and leadership are featured in several TMFs. But the question is if we capture them, because as Sarah said, you would then have to ask questions to individuals, but these are collective concepts. So it's sort of we call it ecological fallacy, that you try to draw conclusions on a collective level by gathering data at an individual level. Professional cultures is definitely not recognized, hardly at all, surprisingly. And I think this research on the relevance of leadership is still quite underdeveloped. And the third social group level is routines, which I found interesting because we are increasingly developing these care pathways. And I think that's quite similar, that we are establishing certain patterns of actions involving multiple participants, for example, multi-professional teams. And if we have these routines, it might not be so obvious that a new intervention is going to be in sync with the routines. And I think if you saw Jeanette yesterday, she has done research on flow culture. She talked about that they have a certain routine in emergency care departments where they have to clear and have beds available for newly admitted patients. And then they were told or asked to implement a new way of working, and that totally disrupted their established routines. So I thought that was a good example of how routines could make implementation more difficult. And they have of course, they have a goal, an aim, a purpose. But they can be disrupted if people sort of deviate from it. So just a couple and quite briefly. It's undeniable that organization also influence the behaviors of individuals with decisions and policies, etc. And as Sarah said, I also consider this an untapped resource. And I will just address a couple, of which I think complexity theory is almost too complex to do research on. But organizational climate, I think, is highly relevant and easier to capture, because we can use, there are many surveys, questionnaires. So this is an aggregate. You can actually investigate it at an individual level. That's how it's usually done with surveys. And this is how you perceive your work environment. And it's similar to, often confused with, but not the same as organizational culture. Organizational climate is more narrow and shallow, and is probably much easier to change, and you can measure it. Culture is usually not quantitatively measured, rather more observational studies. I think some said that the climate is the mood of a person, whereas the culture is the personality. So the personality is something more, well, not etched in stone, but more permanent, and climate is something that can be influenced. And there has actually been an adaptation of the concept of climate to implementation climate. And it's about the extent to which an evidence-based practice or an innovation is rewarded, supported, and expected. So organizational climate, if it's a poor working environment and low job satisfaction, that will probably influence the opportunities to succeed with the implementation. So I think it's quite easy to see, recognize that this could have influence on implementation. And complexity theory, which Sarah mentioned, and it views, and you could view healthcare as a complex system. Excuse me, made up of many different parts, and they interact in a sort of non-linear fashion, and that makes it difficult to implement interventions in a sort of ideal linear step-by-step process. And Braithwaite said that implementation takes place in settings where there are many different actors, different interests, capacity, and time. So essentially saying that it's sort of a perspective, I would say, you could call it a theory, but on organization as very complex adaptive systems. I've seen advocacy for this, that it should be used, but I've not really seen that it's been applied in studies. So, to some wrapping up, and I think this is a key question: how do we know which theories or concepts provide the best or the fullest, the most comprehensive explanation or understanding of implementation? We have assumed that thus far that psychological theories do that, but that might not be the case. So I think this is a relevant but very difficult question. So in some summaries, I would say that many of the theories and concepts in implementation science take a systems perspective. We recognize that problems are at several levels. But then another question is that how we do research? A multi-level perspectives are evident, but the emphasis differs. TDF is clearly more individual oriented than the Sphere, for example. And what level is most important? That's a difficult question. Some research on, I think it's called situationist, situationism. Weak situations is when we decide ourselves, no or little pressure regarding an appropriate behavior. And my idea here is that if no one is watching, some people would probably cross against red light. Here, a strong situation probably yields more similar behaviors. Again, sort of underscoring the importance of the social group. So the question is, the environment, the setting you research, is it characterized by weak situations or strong situations? And I think it's interesting that when this whole evidence-based movement emerged, it really was to convert weak situations when everybody did as they pleased, as they wanted, use their clinical eye or whatever. And the idea was really to convert that to strong situations where everybody is acting in compliance with the guidelines. I think this also, we touched upon that. People are, based on their background, I would say, perspective, they would have different opinions on this. Edgar Schein, leading organizational culture scholar, he argues that 90% of our behavior is driven by culture. And this is probably not something a psychologist would agree with. So you can see here that this question of what level is most important is sort of, it depends on whose perspective you are taking. Culture, climate, leadership are part of many TMFs, but the tendency is still to focus on individuals. We have been more influenced by psychology, and that's the question I asked Sarah. It comes with the tools, but I also think many of the early researchers in the field had a psychology background. And here is a critique, but it's not from an implementation journal. I think sometimes it's sort of difficult to go against sort of an established culture, really, you could say, that the focus is on individuals. They talked about, they argued that we are looking too much at the proximal surface influences and we neglect the deeper influences on behavior. So again, this question to which I don't have any perfect answers. So that was the last slide. So if there are questions, and this seen below is how the question mark was developed out of the, I guess it's Latin word questio, and they abbreviated first to the Q and the O, and they put together it, and it became our question mark. I didn't know that, but I thought it was interesting.
Yes.
Nothing to do with the implementation, though. Or maybe you could say that it's been widely implemented, the question mark.
That's why
Okay.
we have a more straightforward way and transform it into a habit of writing a more simple mark.
Yeah.
So
Yeah.
is there any questions from the audience? Oh, there's a question for Sarah. Maybe Per, you can try to answer that as well. So someone from the audience asked whether they should actually use organizational theory instead of just using implementation theory when doing research.
About when? Yeah, I guess that's sort of my question on when should we use, at what level should we address. And I think it's easy to go the default way of using something from implementation science, and then it would be COM-B or TDF. But yeah, I guess you have to sort of come up with arguments that this is more relevant in this case. But there is no clear guideline, but I guess it would be a bit like that you perceive that here it is probable that an organizational theory would be more relevant. But it's a difficult question, and there is no right or wrong answer. Sorry.
My feeling is it depends on the nature of the intervention. There's a slide that you mentioned that in the early days of implementation science research, people tend to focus, okay, there's an evidence-based intervention, there's a guideline, I want to implement it, and we change it from weak to strong situation. So the intervention object that I want to implement maybe is quite straightforward. Okay, use drug A, don't use drug B, right? So the nature of the intervention is when it is more simple, then probably the more, I would say, traditional or psychologically based implementation strategy may be more applicable. And that's why in the old days, we have a lot of psychologists working in the field. But increasingly, implementation science, we have moved to a stage where we use it to solve more complex implementation issues. So for example, Professor Yo yesterday, they're talking about the introduction of physiotherapists as a first-line primary care provider. So this involves a change in professional status from where you have to get referred to an independent healthcare practitioner. And that, of course, will require a lot of changes in the health system, the patient behavior, and more importantly, the interests of different, healthcare professionals. Maybe some of the healthcare professionals will think that, oh, their role is being taken away and power is being redistributed. And in that kind of intervention, it is way much more complex than changing the drugs that you're prescribing. So therefore, I do agree that actually we have to use different perspective and probably more often in multiple lens to look at one single issue. You can use TDF, you can use CFIR, of course, to look at a complex health system level intervention. And at the same time, maybe the core issue is about the culture. And if we don't have, let's say, a culture of interprofessional collaboration, then it's actually much harder to do this kind of task.
Yeah.
Distribution, for example. So probably the way Per, I think it has to be an assessment of the situation. It's like a contingency theory. It depends on what sort of intervention you want to implement, and you have to think about what may be the core issue, and then you choose the appropriate framework or theory.
Yeah, I think you're right that the field probably started with more simple implementation objects. Maybe I think there were many more guidelines, one at a time. So that made it more natural to use the psychological theories. But I totally agree, and I think Professor Geo's example was a very good example of that. It's become, I guess, the setting and what you implement has become more complex, and then it seems like these theories we recognize that they are not sufficient to totally understand what is happening. So I think it's a progress over time. I agree.
So as we are moving towards a more complex understanding of the implementation research process, and we accumulate so much experience from using psychological theories already. So let's say whenever you are changing the physician's behavior in prescribing, okay, don't use drug A, use drug B, do you think eventually we will have a set of standard implementation strategy for more simple intervention? Because nowadays we know what sort of things may be working anyway, no matter what the context is. So people can actually invest more time and energy, try to change the organizational culture, try to improve the leadership, so they create that environment for people to change their behavior. Do you think there will be a transformation of implementation science focus from the individual behavior to the more macro organizational behavioral?
Yeah, I think, and I know that Sarah has thought about that it could essentially merge with organizational research, because I think, I mean, it's so similar, and it's becoming more similar. It's about organizational change, really. I mean, you can still call it implementation science, but it's, so I think in a longer term it might fuse or be more overlapping research. I do think that.
Thank you. So we have got one question from the audience. Is Eliza. Can we describe organizational theory as a top-down approach, whereas implementation theory aims at a more bottom-up perspective?
I don't think so. I think I am often, or not maybe so often now, but when we started doing research on implementation science, they often said, oh, you're doing this top-down research. But then it was these guidelines and authorities coming up with various policies, and it seemed very top-down. How is this received by the practitioner? So now I'm not sure if there is any difference. I think organizational theory and implementation theories, I mean, I wouldn't say it differs in terms of top down or bottom up. Well, what's your take? I don't think so anyway.
Probably is a comprehensive understanding will facilitate the most comprehensive analysis. Sometimes it's the how do the organization actually facilitate it from a top-down perspective, and how the frontline practitioner will respond to it. So you have to understand it from the bottom-up perspective as well.
Yeah.
And also Sarah actually focuses on the middle managers. And I think they are the key people who actually determine the fidelity of the intervention actually being delivered, or the quality of care being delivered. Because at the end of the day, you will have to, at the frontline level, you have to have people who actually look after the process. And that's why I think it's very complex. And whenever we choose to use one theory, probably we are a bit confined by the fact that we are using that. But I think increasingly we should actually look for a multi-level perspective where we borrow both psychological and organizational theory to look at things more comprehensively. And that may be the way to go to innovate new ways of thinking. All right.
Yeah, I think it's I think with the AI is coming strongly, and AI there are differences. It's not maybe, I mean, the evidence it's not similar. And I got some also read that AI changes over time, and there's data drift, whatever there. So when we implement something, an evidence-based practice, we recognize there's evidence and this is how it will be, although we know that there's some adaptation. But AI will be quite differently, I think, and then will also change the ways of working and the pathways, etc. So I think that also speaks for a more organizational perspective on the implementation. But that's I think it has more research will be devoted to AI implementation.
I think this is more of a classic example of complex intervention, because let's use breast cancer screening as an example. We use mammography to screen for breast cancer, and then we can use an AI to help the radiologist to identify the pathology, right? So in that case, there are many ways that AIs can be added in the screening pathway, and that will affect subsequent follow-up with the patient and the workload of the radiologist, and also how errors should be managed in that situation. So there are many organizational, legal, ethical issues associated with the technology itself, and the technology itself is constantly evolving, because with more data, you'll be able to improve, or sometimes instead introduce bias into the AI model if you're not careful. So the intervention per se is not stable, and it's going to be affecting many aspects of the care pathway as well. So this is very, very complex intervention from my understanding. And the evaluation of AI is hugely complex. Therefore, because you can't use a typical RCT. Today you confirm the performance, and tomorrow it change, and the conclusion may be different. So there has to be another way of real-time monitoring of the AI performance, and according to performance, you have to adjust it. So the whole implementation of this creature is also different from the West. The healthcare intervention. So I'm very excited to see what sort of implementation strategy could be devised for such a dynamic intervention.
And it's also you also have the challenge of I mean, scaling up. It's probably very context. You cannot generalize it and be sort of certain that this AI solution will work in another hospital with other patients. So because we usually assume that we can scale up something that works. So there are some additional challenges, I think, with AI. But I mean, AI is coming regardless what we say. And there will be research. And I read also that the sort of requesting research, they call it the last mile of AI, because the technological aspects, these are technicians working on, but how is the implementation and monitoring going to work in real world situations? That's for research to learn more about.
Yeah, it's going to help implementation science research as well. I think that presents a big challenge for us as implementation researchers, and it is up to us to think about what may be the innovations that will allow us to upgrade the research, the last mile of research in AI in healthcare that actually translated into population benefit. Okay, is there any more questions? So if not, then thank you very much, Per, for this excellent and very interesting presentation on these very important new insights on possibly informing the future of implementation by research by using theories from other disciplines. So thank you very much for joining me in this third seminar of the Implementation Science series. We'll have 1 day of a break, so I will see you again on Friday evening at the same time, of which we will have 4 presentations on implementation of digital and AI solutions in healthcare. So we will extend our discussion on Friday. Okay, see you all on Friday. Bye-bye.
Thank you.
Bye.
Bye.